Ethiopia is one of the oldest countries in the world. We have a population of 90 million people, which makes Ethiopia the second most populous country in Africa after Nigeria. Ethiopia is also one of the fastest growing economies in the world. It has recorded double-digit growth over the last 10 or so years. And this has made Ethiopia the fourth largest economy in Africa, in sub-Saharan Africa. When it comes to health, our health system is organized in 3 tiers. At the base of the pyramid, we have what we call a primary health system. A primary health system is comprised of 1 health center and 5 satellite health posts for a population of 25,000 people. Over the last 10 years, we have massively expanded access to primary health care in Ethiopia. We constructed around 16,000 health posts, and we have constructed 3,500 health centers throughout the country. And this means, on average, 95% of Ethiopians live within a 30 minutes walking distance from a health facility. Ethiopia has done remarkably well in achieving most of the health-related MDG goals. Ethiopia has reduced new HIV infections by more than 90%. At the peak of the HIV epidemic during late 90s and early 2000s, Ethiopia had really suffered with high prevalence of HIV, high incidence of new HIV infections. But because of the concerted effort we have done, new HIV infection rates have gone down. Malaria has been a huge problem in Ethiopia by causing epidemics, generalized epidemics, and causing a lot of deaths and illness in the past. But over the last 10 years, we never had a single malaria epidemic in the country, and the disease has been under control for the past decade. This has resulted to reduce malaria-related diseases by more than 70% and malaria case load by 60%. We have also reduced tuberculosis, which has been one of the top 3 killer diseases in Ethiopia, and we reduced new infections and we reduced morbidity and mortality from tuberculosis. We have also done very well in terms of improving child survival. In fact, Ethiopia has achieved its MDG goals 3 years ahead of schedule. And child deaths has been cut by more than 2/3. We have also reduced days of women because of pregnancy. So Ethiopia has reduced maternal mortality by 69% over the last 20 years. And we are on track to achieve the MDG-related goals related to MDG 5. We have all this was possible because of the innovative health service delivery model we have introduced in the country, which is considered by many as a model for Africa and the rest of the developing world. This innovative health service delivery model is called Health Extension Program. So, in early 2000, when we had all these huge health problems, the government realized that access to health workers and access to health facilities have been limited because most of the health facilities we had in that period of the time was concentrated in urban areas. For instance, we had around 600 health centers, and most of these health centers, primary health centers, were concentrated in urban areas. So we decided to scale up access to medical facilities by expanding our network of health centers, but at the same time to train and deploy health extension workers. So, training doctors is going to take a lot of time. Training nurses and midwives was going to take at least 4 or 5 years. So the best way to avail services and have a huge return on investment is to train low-level cadres of health workers who can provide some of the basic services like immunization, family planning, and treatment of common diseases like malaria and childhood illness. So that was why the country decided to introduce these new cadres of health workers called the health extension workers. So we have trained and deployed 38,000 health extension workers. These are government salaried, high school graduates with 1 year training on essential health skills, and they are recruited from the same community where they go back to serve, and all of them are females. So the country's huge health problems are mainly related to mothers and children. So a female health extension worker, 2 in every village throughout the country, had really helped the country to improve health outcomes by reducing all these, preventable diseases we had in the country, but at the same time, by increasing uptake of critical services. If you take, for instance, family planning, in 2000, only 6% of married women were using modern family planning services. Today, 42% Ethiopians are using modern family planning methods. So over 14 years, a 7-fold increase in coverage of modern family planning services. And this was possible mainly because of the health extension program, because 70% of the women are accessing the service from the health extension program. And if you look at the gain, the increase in uptake of family planning services, it is a poor, it is uneducated that has really contributed to this massive increase in modern family planning services. I can give you a number of examples that has been achieved because of this health extension. In Ethiopia, there are few things that we do differently. The first one is we are, the champions of country ownership. In global health development, even though it is with good intentions, there are, things that are designed and prescribed to poor countries, like in Africa. So a program designed in Brussels or Paris or New York or London may not necessarily fit into the local context in Africa. So we don't accept, prescriptions from our development partners, regardless of whether they are, well-intentioned or not. We truly, honestly believe in country ownership, meaning countries designing their own strategies, coming up with their own ambitious plans, and and mobilizing, rallying support towards that plan. So country ownership is translated into primarily, national plans. So in Ethiopia, when we develop national plans, we engage all our development partners. We set targets, and whenever we set targets, we are always told these are too ambitious, these cannot be achieved. But we always say that if we put all our efforts, if we put a concerted effort into these ambitious plans, we might end up, achieving these ambitious goals. I can give you one example. In 2005, in 2003, we had a huge malaria outbreak in the country, a generalized malaria outbreak. and many people died because of that outbreak. And malaria in Ethiopia is seasonal, meaning it happens just after the rainy season, when farmers have to harvest their produce. So having a generalized epidemic not only costs the lives of people, mothers, children, and the productive segments of the population, but it also affects the economy, because it comes at the peak of the productive season. So we had that huge problem in 2003. So in 2005, we said, okay, we are going to scale up the delivery of mosquito nets to every household living around the country. So the target was to distribute 20 million mosquito nets to 10 million households, 2 at least per house. We had no money at the time, no committed money. We didn't have the infrastructure to deliver 20 million nets throughout the country in such a short period of time. But we believe that by having such massive scale up of intervention, we will be able to significantly reduce the target. And some partners were saying, well, this is like being silly. You cannot have without putting the infrastructure in place to distribute mosquito nets. It is impossible to set that target. So at the end of the year, we managed to distribute 18 million mosquito nets. 2 million short of the target, but it's nevertheless a massive achievement in its own right. Again, a similar example, when we say we will construct 3,500 health centers in the country in just 5 years. People were saying, how is that possible? After 5 years, we constructed 3,000 health centers, 500 short of our targets, but again, this is a massive achievement. So it is about coming up with the ambitious targets, driving the strategies, and having the plan, and to have a steadfast commitment to your plan. So when we constructed the health center, we introduced what we call a matching concept. So Ethiopia is a federal state, in terms of a governance structure. So we have 9 regional states and 2 city administrations. So we said, we try to mobilize resources from the likes of the Global Fund, Gavi, the World Bank, and other development partners like, PEPFAR, the US government HR response. So we worked with all our development partners, and we said, if you help us raise capital for 1,500 health center construction, we will be able to mobilize additional resources from local governments to match, those numbers with additional resources locally, so that we can have a huge impact. So that was how it was possible to construct this massive number of, health facilities in such a short period of time, by mobilizing international resources, but leveraging that resource to mobilize more domestic resources to construct more health centers. So constructing a health center means that the local governments will take more responsibility, because they have to employ health workers for those health facilities. They have to allocate budget. So in the short run, when you ask donors to construct a health center, it may seem expensive, but it means that, the local governments will take over more responsibility in the medium and long term, because they have to avail resources to provide that. So country ownership and doing things at scale, with such the examples I used, are 2 distinct features of what we do in Ethiopia. But these are from the supply side, from the government side. But what makes Ethiopia unique and innovative in many ways is we engage communities. We have, using our health extension workers, who live with the community, who are from the community, we organize people, particularly women, to to have to build on the social networks we have, the cultural networks we have in improving health outcomes. Since 3 years ago, 4 years ago, we started a new initiative called Health Development Army. This Health Development Army is an army of 3 million women volunteers across the country that are organized into smaller groups to talk about their health, to talk about the health of their children, and how they can, rally support to improve, the health and well-being of the community members collectively. So by using this army of women, we managed to increase uptake of critical services around the country, particularly those services that have historically been not well taken, like giving birth in health facilities. 5 years ago, only 10% of women were giving birth in health facilities. Why? Because of tradition, because of culture and religious reasons. Women prefer to give birth at home unless there is complications. They give birth at home. But in a country like Ethiopia, which is predominantly rural, unless you give birth in health facilities, the likelihood of the woman dying from pregnancy-related complications is very high because getting transport is difficult, access to good roads is difficult, and calling ambulances is not easy in some instances. So it is really important to go and give birth in health facilities right from the start. But despite all the efforts we did, the service didn't really pick up. But when we introduced this Health Development Army, the innovations came from the Health Development Army. When these women groups were asked, why can't you help us, in increasing uptake to, in increasing the coverage of health institution, delivery. They said, look, in our culture, women have to go through some cultural rituals, like having coffee ceremonies during labor, having a porridge ceremony, porridge eating ceremony after birth. Unless these things are availed in health facilities, we believe that something bad could happen to either the newborn or the woman. So they said, if you let us avail these services as groups in the health centers, women will come and institutional delivery will increase. And this innovation is now working in many places where they have a very strong health development. Institutional delivery rates are now 60%, 70%. A huge increase from the 10% that we had 5 years ago. Now we still have a long way to go, but as you engage communities, they come up with innovations. So we work with donors, and Ethiopia has received unprecedented support from our development partners. When you deliver, when you demonstrate that the plans you have developed, the strategies you have set in place, the policies you have designed, deliver results, donors always support you. And this is what we always try to demonstrate whenever we discuss with our donors. Look at our track records, we deliver, we account for every support we have received, and we are also accountable to the communities that we are serving. So this is a guiding principle that we engage with our donors. I'm here as part of the ACP Ministers of Health meeting. We discussed, deliberated by taking stock of, the progress the ACP countries have made toward the MDG goals, the challenge we still face, and we discussed about the post-MDG, health-related discussions and what needs to be the priority and how we can further, increase South-South collaborations and so on. But I have also met with EU Commission officials to discuss bilateral support Ethiopia has been getting from EU. EU has been supporting the Ethiopian health system, particularly during the emergencies in the past, but since 2 years ago, they have also started supporting maternal and child health programs in Ethiopia. We are discussing about sector support for the health sector in the next EDF, in the 11th EDF, and we will continue to work with country office in Ethiopia and officials here to support our own plan, which the EU has agreed to support. When it provides sector support, it means that there are no prescriptions. Your plan is good enough to be supported, and what we are expected to deliver is results. So it's a result-based financing arrangement that we are discussing to put in place. So we will be happy to deliver the results, and we will use the resources to finance the national priorities and plans we put in.